Good morning, everyone. I would like to present our presenter today, Dr. David Miranda, who's known to many of us. David graduated from medical school in Costa Rica in 2009, and then he completed his internal medicine training at Hennepin County Medical Center. During his internal medicine residency, he's been involved in many research projects and also was inducted into the Alpha Omega Alpha Honor Medical Society as the Resident of the Year. He then started his cardiovascular fellowship at Abbott and HCMC, and again continued throughout his research on cardiac arrest, hypothermia, and ECMO. He's been involved in many projects with our team, and is gonna move on to advanced heart failure fellowship when he graduates this fellowship. So he'll present a couple of cases today. Welcome.
Thank you. I have a mic. Can everybody hear me okay? Well, good morning, and thank you everybody to come this morning. So as Dr. Ranowitz says, I'm going to present these two cases today. So the objective of my talk today is review two interesting cases about end-stage cardiomyopathy that had successful heart transplantation here at our center. Also, I want to briefly review the heart transplantation program at the Minneapolis Heart Institute, a little bit about the outcomes and how have we doing in the history. And then the role for endomyocardial biopsy in the diagnosis of adult disease. Okay, so let's start with case number one. So this is a 61-year-old male that was diagnosed with non-ischemic cardiomyopathy back in 1998. When he was diagnosed back then, he had a biopsy and he had a coronary angiogram, so this was his underlying diagnosis. He did well over the years. His EF was around 40 to 45%. He was pretty stable from heart failure symptoms, but then over the last few days, so over the last few months, he had progressive decline in his clinical heart failure. He developed progressive shortness of breath, progressive lower extremity edema, and then he got symptomatic VT. As I said, he already had an ICD for primary prevention, and he had multiple fires from this ICD, multiple shocks, sorry. So as, this patient was followed primarily at another hospital, and the cardiology service and the EP service had been evaluating him, trying multiple antiarrhythmics. He even had multiple ablations, both epicardial and endocardial, without any success. So he, after ablation number 5 that was not successful, he was referred to our center for consideration of a heart transplantation. It's important to note that these PTs were symptomatic. He developed palpitations, dyspnea, syncope, and as I said before, ICD shocks. So his past medical history is long, but I want you to pay attention to his cardiac past medical history. As I said, non-ischemic cardiomyopathy with chronic systolic heart failure. He had recurrent VT, and he has paroxysmal atrial fibrillation. Of note, he had this diagnosis of adult polyglucosan body disease. So this is a rare neurologic disease that was diagnosed 2 years prior at Mayo Clinic because of his, he had several symptoms of this neurologic disorder. He had peripheral neuropathy. He was very unstable on his feet. And then he has some interesting bladder incontinence. And then as part of this disorder, they developed erectile dysfunction. So a little bit of a social history. So he's a family physician. He's young, but he had to retire earlier because of all this symptomatic VT and his clinical heart failure. So he was basically housebound. He was unable to drive or even get out of his house due to the frequent VTs. He's a non-smoker. And important in the case, he doesn't have any Ashkenazi Jew ancestry. Family history, it's important that he doesn't have any neurologic disease and no history of cardiomyopathy, no genetic cardiomyopathy. So on exam, when he comes to our center, his vitals are pretty much stable. And then the important thing of note in his cardiovascular exam is that he has some lower extremity edema, elevated JVP, and bilateral crackles consistent with his clinical heart failure that he was presenting. So his labs are unremarkable. His troponin was mildly elevated, and he had a coronary angiogram with no obstructive coronary disease. The prior echocardiogram that we had was from 2 months before, where he had an EF mildly reduced from 40 to 45%, no MR, and no regional wall motions abnormalities. So this is his first EKG on presentation. As we can see here, it's pretty unremarkable EKG, other than a little bit of sinus back. Here's his echocardiogram. This is the repeat echocardiogram when we admit the patient to our hospital. So in direct comparison, there, the MR is a little bit worse. And then EF, it's read as worst, so it's read as 30%. And he had some wall motion abnormalities that are read as well. Interestingly, he developed a little bit of AI as well in this echocardiogram on admission. So as part of the workup, as I said, angiogram that was pretty unremarkable. The discussion when we were admitting the patient in working up this progressive VT is that if there's a progression of coronary artery disease, but as we can see in his current angiogram, there's no evidence of progressive coronary artery disease. He had an LV-gram that showed his EF is reduced with predominantly an anterior wall motion abnormality. So as part of the workup of this progressive VT and progressive clinical heart failure, he undergoes FDG PET. So let me walk you guys through this. So this is the perfusion study. This slide, and as predicted, is completely normal because there's no coronary disease, so a completely normal perfusion study. But then the FDG PET part is read as there's some areas of uptake, especially in the anterior, in the mid and basal, and then in the anteroseptal wall. Interestingly enough, if you can see here, the free wall of the RV over here, there's uptake as well. So the official read for this is that this FDG imaging is abnormal. So the LV was mildly dilated, and then there's an uptake that is consistent with active sarcoidosis or other inflammatory process on the heart. So there's discussion as well because he just had a VT ablation a week before this test. So the significance of the positive FDG PET in the setting of VT ablation, it's unknown, or it was unclear what was the significance of this. So he was interested. I want to note that he had failed every single antiarrhythmic before. He developed toxicity to amiodarone. He developed significant side effects to lidocaine and other antiarrhythmics. So he was discharged on a different regimen, but then he was readmitted with cardiogenic shock, and he was inotrope dependent. So his status was upgraded to 1A. So at this point, it was a very unclear diagnosis. So he undergoes cardiac biopsy, and I have Dr. Sanderson from Pathology here, and here's the first slides, but I wanna ask for your help in here.
So as you can see, the microscopic pictures here of the endomyocardial biopsy, the highlighted picture there in the bottom right really shows what's going on, but you can see a slightly lower magnification view in the top left there, maybe half a dozen cardiac myocytes that are expanded, their cytoplasm expanded with this pale gray material that when you look at it under high magnification, looks like just sort of this packeted material. It's clearly abnormal, it doesn't belong there. In the background myocardium, really no significant inflammation and no myocyte necrosis. So this sort of thing you can see in the legend there, that it was stained with PAS stain, which is periodic acid shift, which stains glycogen, and this stains strongly pink.
Okay. And as part of the further workup, we test for sarcoidosis, amyloidosis, right? And I think these are the ones up here.
Exactly. So you can see for all of our endomyocardial biopsies, we stain them with iron stain, and amyloid stain, sulfated Austrian blue, as well as a trichrome and standard H&E. This obviously didn't have any iron, but we did come across this pale gray material, which you can see on the right there, stains beautifully with the periodic acid shift reagent. So it's that nice bright magenta pink of glycogen. We don't see polyglucosan disease in the heart every day. So I was on the phone with Dr. Mackey on Friday, and she's obviously the cardiac pathologist overseeing the cardiac registry, Jesse Edwards Registry. This is the only disease out of over 30,000 cases in their registry, so fascinating.
So in this one, all those, this is the myocyte, and then all these are cytoplasmatic inclusions that displays the whole nucleus to the periphery and creates significant cardiac dysfunction.
Exactly.
Okay, so this is the official report of the orthotopic explanted native heart from the Jesse Edwards Registry. So basically, the report showed the basophilic material inside the cardiac myocyte. There was an increased myocardial fibrosis. There was marked cardiomegaly. The heart weighed 640 grams. So usually for his height and his weight, it's between 325 and 566 grams. He had congenital bicuspid aortic valve, and he had multiple cardiac ablation procedures, both in the right and left ventricle, and multiple device leads. So this is a picture of his actual heart that we got from the registry. So in this first two, we can see the RVOT ablations that he had. All this white part in the endocardium is the ablations. Also in the LVOT, he had ablations. This is bicuspid aortic valve, and this is where he had an ablation. And also he had ablations in the LV, in the endocardium part. So multiple ablations, multiple fibrosis in his heart, and then we have a cross-sectional picture of his heart as well that showed large heart, and we're discussing with Dr. Shannon McKay, and it's unclear if this area is this is scar clearly, but if this it's fibrosis specifically, clearly it's not a coronary distribution for fibrosis. So this was the actual pictures of his heart. And he underwent cardiac transplantation, and this is his echocardiogram after his his transplant. So a little bit of adult polyglucosan body disease. This is a rare glycogenesis. So it is, the primary manifestation is mostly a neurologic disease. So it starts with paresis that are ascending, and they're very progressive, similar, and then they cause neurogenic bladder with incontinence. The diagnosis is usually delayed between 6.8 years, since it's so rare. It's autosomal recessive, and the glycogen branching enzyme is deficient. So this leads to the accumulation of this polyglucosan body disease, mostly in the central nervous system and the peripheral nervous system. So they have both peripheral nervous system manifestations as well as some central nervous systems with to the point that they develop dementia. The more frequent ancestry are Ashkenazi Jews, and the reason is because two of the founders have this GBE1 mutation gene. So in the whole English medical literature, there's fewer than 50 patients with this that they've been described. And this paper that I found in the Journal of Neurology was the one that had all 50 patients, case reports, and all the patients. And basically 27 of them were from Ashkenazi ancestry, so 90%. And most of them present as is described with neurologic dysfunction, but none of them had any cardiac involvement, and none of them had biopsy-proven cardiac involvement. So as we all remember the biochemical pathways of glucose, if we have glucose here and then we use glucose down to lactate, that's the pathway of glycolysis. But then if we want to produce glycogen and we store glycogen in our cells, we use another pathway to go up and store glycogen in the cells. So this glycogen can be reutilized as a glucose when there is periods of starvation. So this is the enzyme that is efficient in this disease. So the glycogen is stored in many cells. And then it's unknown to everybody why it's most notable in the neuron. But in this case, it happened in the heart. So the unique characteristics of this case, this is the first case of cardiac adult polyglucosan body disease cardiomyopathy in the literature that has a cardiac biopsy proven diagnosis and a successful transplantation. And I'm happy to report that we saw the patient in March at the clinic appointment with Dr. Bennett, and he was doing really well 1 year post-transplant. He went to winter in Texas, and the only thing is that he got a flu-like illness, but other than that, he's feeling really well after his transplant. So now with that first case, I want to shift gears a little bit and talk a little bit about the outcomes of the heart transplant program here at the Minneapolis Heart Institute. So the Abbott Northwestern Heart Transplant Program was established in 1985. So from 1985 through December of 2016, we have done 411 patients for a total of 418 heart transplants at our center. So the 1 year survival for this entire group is almost 88%. And the 1 year graft survival is 86.8%. And then the patient survival at 5 years is 78, and at 10 years is 63%. So here's the heart transplant volume. So in the pink line, we can see the patients that we list ourselves. And then in the blue line, the referrals that we get from other centers. So as we can see, we have been growing since 2000. And have we been getting better? Yes. So the 1 year survival for the whole group since 1985 is almost 88%. And as I said before, the 1 year graft survival is 86.8%. But then if we move to the most recent 5 years from 2011 to 2016, the patient survival at 1 year is almost 96% as well as the graft survival. So if we get only the last 5 years, we have a graft survival in a patient survival of 1 year of 96%. We've been growing in volume as well. So the number of heart transplants since 2000 has been growing to the point of last year that we did 33. So in 2015, it was the first combined heart kidney transplant, and then the next year we did 2 combined heart kidney transplants. And this is the Kaplan-Meier curve for the 1 year survival of the period between 2010 and 2015. So the SRTR registry publishes every year the survival data of heart transplantations, and we compare, and if we want to know how we're doing nationally, if we want to compare our center with the rest of the nation, here's an example. So 1 year survival for our center is 95.2%, and then for the whole U.S., 1 year survival is 90.5%. So this cohort is between 2013 and 2015. So now going to our second case, this case we published in the Journal of the Minneapolis Heart Institute Foundation inaugural volume that was published this last winter. So it's a case of giant cell myocarditis. So this guy is a 56-year-old guy. He's previously healthy, no past medical history, and he had several pre-syncopal events. These pre-syncopal events just started like 6 weeks prior to coming in. And then he had frequent visits to the ER where he was diagnosed with multiple variety of symptoms or of diagnosis, but never got to the point of his cardiac condition. So he's a non-smoker, very active individual. He exercises, and as I said, no major medical issues. So his exam, his vitals are pretty unremarkable. His cardiovascular exam as well is really unremarkable, and his labs are completely normal except for a troponin of 3.8. So of note, he had an echocardiogram 6 days prior to the presentation that had a normal ejection fraction. So this is EKG on presentation. So interesting EKG that has diffuse ST depression in multiple areas, consistent with, and then with that troponin elevation, it's concerning for some type of coronary artery disease, active ischemia. So he undergoes an angiogram, and well, the angiogram didn't show any obstructive coronary artery disease as well. So as part of continuing the workup, he has an MRI, and then the MRI shows multiple gadolinium uptake in portions of both the epicardium and the endocardium in the left ventricle, the right ventricle, and the septum. So this is clearly very suspicious for myocarditis. And the next step in this case will be the cardiac biopsy. But interestingly enough, he gets, well, and then first of all, he gets the complete workup, viral serology, and then he gets the first cardiac biopsy that it's unremarkable. I'm going to show this in a while here. But he has progression of conduction disease abnormalities, and then he develops ventricular tachycardia as well, sustained. And this is the first cardiac biopsy. Anything to add here, Dr. Sanders?
Again, looks completely normal. So we stain with hematoxylin eosin, and you're seeing is really effectively in an eosin-only stain with just rare, well, little bits of hematoxylin of cardiac myocyte nuclei, but there's no inflammatory cell infiltrate here. Everything looks fairly uniformly spaced. There's no dropout. There's no necrosis, no infiltrates of any kind. Okay.
So this is the first biopsy that he gets, and as I said, he was discharged. But then he comes back when he had recurrent VT. He had recurrent symptoms of his pre-syncopal events, and this is the second heart biopsy that we obtained.
So really a completely different picture right now. No normal cardiac myocytes are in any of these 4 frames here. You can see giant cells, multinucleated giant cells infiltrating throughout that are nicely circled with a background mixed mononuclear inflammatory cell infiltrate that's lymphocytic, a few histiocytes, and fairly prominent numbers of eosinophils, which is characteristic for this diagnosis.
Okay.
So you can have myocarditis with giant cells, which would be fairly typical for sarcoidosis, but this is a giant cell, clearly giant cell myocarditis with that very rich eosinophilic infiltrate associated with it.
And this is like part of the normal myocardium that is being consumed. Or
exactly. So you've got necrosis right there. More giant cells.
Yeah.
More destruction.
Okay. So so basically, in this case, there's for giant cell myocarditis, there's people that advocate for start aggressive treatment, aggressive therapy, and use this as a bridge to transplant or as a bridge to recovery with aggressive immunosuppression. So we started prednisone and cyclosporin for this guy, and we listed for heart transplantation, but as a status 2. We put a dual chamber ICD because of his recurrent as a secondary prevention. But then he had multiple admissions. And then despite antiarrhythmic therapy on him, aggressive immunosuppression, he came with persistent arrhythmias, and he was upgraded to UNOS status 1A. So he undergoes a heart transplantation, and this is the explanted heart pathology. Any other comment, Dr. Sanders, here?
So you can see some of the tail areas, particularly in those left 2 frames of just necrosis, now resolved, collapse, basically, parenchyma, a little bit of scarring, but otherwise looks like the effects of giant cell myocarditis that's been fairly aggressively treated with immunosuppression.
So it could be from the immunosuppression?
Yes.
And then, so his first post-heart transplant, this is the first post-transplant biopsy that he had. And here he had some degree of inflammation, right? So in the ISHLT scale, that is a scale to see how much of rejection a patient is having, he was categorized as a 2. So is this consistent with?
Completely. So you can see a mononuclear inflammatory cell infiltrate on the right side, predominantly lymphocytic. There are at least 2 foci of myocyte necrosis there that would fit perfectly for that classification. Yeah. Exactly. The slightly darker pink and condensed cytoplasm is the telltale sign.
Okay. And then he was aggressively treated again with immunosuppression, and 1 month later, this is the second biopsy that shows resolution of that inflammatory process. So giant cell myocarditis is the pathologic diagnosis. So it's a mixed inflammatory cell infiltrate with multinucleated giant cells that are surrounded by eosinophils, lymphocytes, and occasional plasma cells. So basically a very aggressive inflammatory state. The first reported case of successful treatment with aggressive immunosuppression was back in 1987, and people have been more prone or pushing towards trying immunosuppression first. But still in the giant cell myocarditis registry, more than 50% of the patients undergo heart transplantation. So some unique things about this case is that giant cell myocarditis could present as a very acute fulminant case. And in this case, this guy was pretty healthy, and he came with a very aggressive form of it. He did not develop cardiogenic shock, but he really had intractable arrhythmias. As I said, the patients can be managed as a bridge to transplantation or mechanical devices as a bridge to transplantation as well. And then despite the relative hemodynamic stability of this patient that we had with the attempt bridge to transplantation, he had recurrence of recurrent BT, and that was the clear indication for the cardiac transplantation. So now I want to talk a little bit about the role of endomyocardial biopsy in the management of, yes?
Good question. What was the time frame between the 2 biopsies?
Between
the negative and the 1 positive?
So it was around a week, but that was 1 admission, and then he went home. He continued to have symptoms, and then when we did the second biopsy.
So do you think it was just sampling error, or is it actually?
I think it was sampling error.
Okay. You don't think if you did special studies on that normal, you would be seeing the early signs of myocarditis before you get all the cellular infiltration or anything? No signs?
That's a great question. So I actually personally looked at both of these biopsies and remember signing out the first biopsy is normal. And Dr. Zimbla, he's here, came over with his team to question me, to ask actually, which I really appreciated because it's a chance for us to meet and look at the slides face to face, and it clearly was a disconnect with what was going on clinically. So that was a great interaction. And of course, in pathology, we're always trying to confirm positive patient identification. So this is again one of those situations where we make sure the biopsy is labeled correctly. It really does belong to this patient, but it had to have been a sampling error because that was completely normal biopsy.
Mm-hmm. What is the EKG also?
A rapid progression phase, so perhaps the ability to find the correct spot with your biopsy was greater on the second try.
Exactly, and then one of the things that we thought is like, okay, with the immunosuppression, if he responds, that will be something that we can say that could be a giant cell myocarditis, but then he did not respond to that as we thought. But yes, there was progression of the disease very rapidly.
Sorry, doctor, I will apologize to Dr. Sanderson, but there was something that didn't add up with the EKG and the troponin. Well, if the glove doesn't fit, you must acquit, I think.
Okay, so because of this controversy that goes between clinicians and pathologists, at we can see in this room. The American Heart Association and the European Society of Cardiology came up with this consensus statement about the role of endomyocardial biopsy in the management of cardiovascular disease. And basically, it's interesting because when they talk in the document, they just give expert recommendations and maybe one randomized controlled trial, but basically there's not a lot of evidence in the cardiac biopsy world. So what they did here is basically give clinical scenarios. So they give 14 clinical scenarios where biopsy is justified based on risk benefits. So if we see the first three that are the ones that have more evidence with a class recommendation 1 with a level of evidence B, and then the third one C, it's what we have in our patients, in these two patients that I presented. So the first one, that is the one that has the more weight, is new onset of heart failure less than 2 weeks of duration with a normal sized heart and no hemodynamic compromise. Then the second one, it's a little bit of a more prolonged heart failure, 2 weeks to 3 months, but they have dilated ventricle, they have ventricular arrhythmias, or they have progression of conduction disease with second or third degree heart block. And it doesn't matter if they respond to medical therapy or not. And then the third one is the one that is more significant for our first patient that had non-ischemic cardiomyopathy since 1988. So heart failure of more than 3 months, but if they develop neoventricular arrhythmias or progression of conduction disease, it doesn't matter if they respond to medical treatment or not, it's justified cardiac biopsy. In this case, they give a class recommendation 2A with a level of evidence C. So other indications are listed here, but they're more controversial. So they talk about the myocardial biopsy and its storage diseases. They're mostly for prognostic causes, prognostic uses, right? Because they don't have any, it won't change the management, because the ultimate management is heart transplantation if they have progressive cardiomyopathy. Obviously, there's risk and benefits to everything we do in medicine, and the inexperienced hands is not a very risky procedure, but the one that everybody fears the most is the perforation of the heart that creates significant morbidity and mortality. So I want to thank Dr. Simbo and Dr. Bennett in the Advanced Heart Failure section, Dr. Sanderson here from the Pathology Department, Dr. Mackie Bojack at the Jesse Edwards Registry, and Francis Hoffman, the Director of Heart Transplantation Program, for all the information and the support for the presentation. Thank you. Any questions?
Hi, David. Thank you very much.
Yeah.
A question about endomyocardial biopsy and the use of electrophysiologic direction.
Mm-hmm.
On your giant cell arteritis case, in the base learned for a septum on the right ventricular side, there was a marked increase in gadolinium. And the potential would be that you would direct yourself to that area. So theoretically it works. Is this something you consider because of the skip lesion issue?
So I just had that question when I was doing my rotation EP, and I think before having the imaging part, it's hard to say where specifically the areas of inflammation are. So as I discussed with Dr. Vernick during my rotation, I think that yield for EP-guided biopsy is not higher than the normal cardiac biopsy. Has that been studied in any way, or this is just? No, I don't think it has studied.
There was actually a study at Mayo. One of the residents I used to work with who then went there did publish on a slightly increased yield with EP-guided biopsy. I don't recall that it was a lot higher, and this was looking, I think, particularly for sarcoid. But there's at least one small study supporting it. And we do often ask EP to help biopsy these patients, particularly if it's very patchy or it's an area that may be difficult to access. So the imaging guidance for this, I think, has really been essential because some of these patients where you have a clinical scenario, but then the imaging suggests that the only place that's active is, let's say, in the basal left ventricle right near the valve, where it's going to be really hard technically to get at it, we might forego the biopsy. But we also often have more confidence that someone has, let's say, amyloid, and so we tend to be biopsying more for the tissue diagnosis to prove the subtype rather than to confirm the diagnosis.
You go back to your first nuclear medicine study on that first case.
Yep.
It's not my area, so was that normal? Did you say a normal resting perfusion?
So the perfusion part was normal. That are this slides.
But I'm just curious to say the resting. I mean, it seems like there's a big disconnect between the gross pathology and that.
So this is there's no, so the perfusion study that is this lines are just a rest perfusion, right? And those ones showed no abnormality, right?
Right, but you have all this fibrosis that should have, what's the need for perfusion to areas of scar? I'm just surprised.
Uh-huh.
Well, I don't, maybe it's so diffuse, that it's like that. But I mean, in a lot of, cardiomyopathy patients, say in our stem cell population, their nuclear studies are grossly abnormal. I mean, they have patchy areas of scar throughout. I'm just surprised that.
Even in the perfusion part, in the normal perfusion baseline?
I just want to go back to the biopsy that we also had a few patients that the left ventricle was biopsied. So it is doable by our interventionalists based on imaging. Going back to what John said, especially based on MRI, where there was extensive, LG in the left ventricle. So that can be done as well. And it was, sometimes it was positive, sometimes it was negative. It's doable.
David, great presentation. Patients that have giant cell myocarditis, do you treat them differently in terms of immunosuppression after transplant than, let's say, patient that has ischemic cardiomyopathy?
Sorry, what was the question?
Do you treat patients with giant cell myocarditis after the transplantation in terms of immunosuppression? Do you treat them differently than other patients, let's say, ischemic cardiomyopathy?
Okay, so giant cell, so you're asking from the cardiomyopathy standpoint, like beta blockers, ACE inhibitors, or immunosuppression?
Can the implanted heart be also affected again in this patient?
So yeah, definitely can be affected again. So I would say that from what I read, I wouldn't change the management from the immunosuppression standpoint, but definitely you can have higher degree of surveillance because giant cell myocarditis can recur in the neotransplanted heart.
In our practice, we do change it. I mean, majority of our patients, end up being on no steroids. And for the 2 patients that we transplanted, 2 or 3, remember Peter, I think 2 or 3, our policy has been to keep them on the lifelong prednisone, low dose prednisone therapy because of these issues.
I agree with what Katja said, but no one has ever demonstrated that prophylactic immunosuppression prevents. Sorry. So no one has ever demonstrated that prophylactic immunosuppression prevents giant cell myocarditis. Our experience is immunosuppressing patients with giant cell myocarditis. The second point is that when you have had a transplant, you're a captive audience for surveillance. So it's much easier to diagnose it because we are having frequent biopsies. So if you were to ask for my personal opinion, I would say maybe more vigilance with surveillance rather than, but here, yes, we do keep the prednisone on.
That's all. Have a great weekend, buddy.
Thank you.